Hello, welcome to today's program being put on by CEC Oncology, an all-hands-on-deck educational activity. Today's title is called Spotlight on Clinical Advances in Relapsed Refractory Diffuse Large B-Cell Lymphoma. This is supported by independent educational grants from ADC Therapeutics and Pfizer Incorporated. I'm John Allen. I'm an associate professor of clinical medicine at Weill Cornell in New York City, where I'm a CLL and lymphoma specialist. And here are my disclosures as well as those who helped develop this program. This activity may include discussions of products or devices that are not currently labeled for use by the FDA. The faculty have been informed of their responsibility to disclose to the audience, and we will be discussing some off-label or investigational uses of these products. In support of improving patient care, CEC, or Creative Educational Concepts, is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare system. Please remember to get your credits at the end of this program. Here are today's learning objectives. We hope to integrate diagnostic and prognostic biomarkers for DLBCL in order to develop personalized treatment strategies for our patients, utilize an evidence-based approach for personalizing treatment for patients with relapsed refractory DLBCL, taking into consideration efficacy, safety, and patient-specific factors, and then develop strategies to identify and mitigate the impact of adverse events associated with novel therapeutics used in the treatment of these patients. Here you'll see the epidemiology of DLBCL, showing the age, presentation, and survival rates. You'll see a peak incidence of diagnosis peaking around the 5th or 6th decade of life with a median age of diagnosis of 66 years. Many patients do present with advanced stage disease, with about well over half the patients presenting in this setting. Many have B symptoms. There's extranode involvement common, lung, liver, bone, etc. Bone marrow involvement is relatively common, though not always required for a bone marrow biopsy, as it rarely changes the management of the patient. And CNS involvement is relatively rare, but can be seen at diagnosis several times, particularly in those patients with high-risk disease sites involved, and many times can occur as a secondary relapse. 5-year survival rates look good with 60 to 70% of patients being cured with frontline chemoimmunotherapy. To help us identify those patients who will do well and who might do a little bit worse than others, there are several scoring systems that have been devised. Ultimately, the IPI is the most famous, easiest to calculate, with 5 factors being looked at, though with other scoring systems being used, such as the NCC and IPI, you can better discriminate low and high-risk subgroups, though it's a little bit more complicated to calculate it, and many times I just pull up a online calculator. But nonetheless, we do this for our patients and helps educate them and ourselves of what to expect and the potential cure rates for our patients. Importantly, we do see DLBCL in our really old, our older patients, our significantly older patients who are typically getting mini R-CHOP, which we know does decrease the potential cure rate. At ASH of 2024, there's a new scoring system for these elderly patients that are 80 years or older, incorporating various factors and predictors as listed here up front. You'll need to use an online calculator that has been established, but ultimately it does a very good job and maybe a better job for these older patients who have many other significant comorbidities at identifying those who might do actually very, very well with mini R-CHOP-based therapies and those patients who we need to do some more improvements for. How do diagnostic and prognostic biomarkers fit into clinical practice? Well, classically, we're thinking of the cell of origin when we really are talking about what is the aggressiveness of the disease and what is the potential for cure, etc. We do incorporate it, even though it's not really put into the scoring systems. We do think about our patients based on that cell of origin. And classically, we use the Hans algorithm, which is identified over here on the left, which via immunohistochemistry techniques, we can identify those who are GCB or also known as non-ABC, as well as the activated B cell or non-GCB subtypes. And you can see the GCB subtypes have historically always done better with R-CHOP-based therapies, though we don't change our therapy based on those patients, based on the cell of origin. That was until polar CHIP came around, and now that is shifting to where those patients with the non-GCB or ABC subtype might actually be the ones who are benefiting most from a polar CHIP-based initial therapy, which is evolving how we are using and incorporating that regimen. You can see newer classifications based on genomics and gene expression profiling, which can actually further subclassify our patients within different cell of origin groups and may have some prognostic implication. Now, this is not easily done, not readily clinically available, is something still of a research tool, but we are learning more and more about specific subgroups that might do worse within a cell of origin or might do a little bit better within a cell of origin, and will continue to evolve as time goes on. It's important to note that double hit lymphoma remains a high-risk patient group, and we know that those patients typically have done not as well with R-CHOP-based treatment, and we're starting to move towards R-EPOCH. And as you can see here, historically speaking, we typically see that dose-adjusted R-EPOCH, more intensive regimens might improve some outcomes for these patients with double hit lymphoma. Right now, they're always too rare to identify how they might do in randomized studies like with polar R-CHIP, and typically it is still rather standard approach to use dose-adjusted R-EPOCH for double hit lymphoma patients. Assessing the latest evidence for current and emerging treatment options for relapsed refractory DLBCL. So let's go ahead and get into some of the newer regimens that we might be using in the very near future. So here are the NCCN guidelines for second therapy approaches. And as you can see, it still dichotomizes based on intention to go to transplant and actually the timing of your relapse. For those patients who are relapsing within 1 year, who are otherwise eligible for stem cell transplant or fit for CAR T-cell, the standard of care is to proceed with CAR T-cell, either with axi-cell or lyso-cell, and those patients who have relapsed less than 1 year. In those patients who have relapsed beyond 1 year, who are still stem cell transplant eligible, we are still thinking about standard chemoimmunotherapy consolidation, induction consolidation, and then proceeding to transplant. We do have some bridging options that we think about if those patients are going to go to CAR T-cell therapy, etc. That might be with POLA-R or other chemotherapy regimens, patients who are fit for more aggressive regimens. And we might get their disease as best we can and debulk them prior to CAR T-cell needed for bridging. In those patients who are not thinking about proceeding to stem cell transplant or may not be CAR T eligible, we have now starting to bring in our bispecific antibodies and other novel therapeutics. And with recent data, we're starting to see bispecifics plus or minus chemotherapy, polatuzumab plus or minus bispecifics. We still have our standards with polatuzumab BR, tafasitamab, lenalidomide, and we still have CAR T-cell with lyso-cell being available for those patients who are not eligible for stem cell transplant, but might still be eligible for CAR T-cell who have relapsed at any point in time. There are other options for our patients in these settings, but typically we are thinking about our novel therapeutics in those patients who are not going to proceed with aggressive therapeutics. In our third line and subsequent settings, we have our CAR T-cell approaches as stated here, and that's kind of where they still fall. I think if a patient is eligible for CAR T, they should see it at some point, whether it's in that second or third line setting. And in those patients who have maybe had prior CAR T, may not be CAR T, we do have our bispecific as monotherapy approaches in this setting as well. Importantly to note, based on recent data from ASCO in 2024, brentuximab and R-squared has shown promising data from the Echelon-3 study and now has NCCN guideline recommendations in the third line or later setting. Most of these patients came onto this trial as fourth line with 3 prior lines of therapy, but showed high CR rates and kind of irrespective of the CD30 positive expression, but nonetheless with high CR rates of about 40% in these very high-risk patients getting BV R-squared. We also have loncastuximab and selinexor set up in this setting as well, but we'll see how these are evolving in this day and age with particularly with bispecifics. Here are our CD19-directed CAR T cells that we're clinically using. These are the three products. All three of these products are approved in the third line and setting, or third line or later setting. And remember that axi-cel is unique in that it's a CD28 co-stimulatory molecule. Tisa-cel is a 4-1BB co-stimulatory molecule. Here is a summary of how we administer these agents and the type of lymphodepletion that is common with these agents, as well as their FDA approval status. Note that axi-cel as well as tisa-cel also have approvals in follicular lymphoma, liso-cel as well there in that space too. CD19 CAR T cells for DLBCL, this is the original data showing 40% durable remission rates in these patients who were getting this in the third line or later setting. We do see improved outcomes basically as we start to move these agents up in terms of CR rates, etc. But yes, in this original data sets, we were seeing about 30–40% CR rates, and it is really these patients who might have durable remissions. As you can see, those patients who had these CRs could actually have meaningful remissions starting to get out several years and actually seeing a plateau in the PFS curves. Important to note, though, that CAR T-cell is associated with a little bit increased toxicity in terms of CRS as well as ICANS comparatively to other immunotherapeutics like our bispecific antibodies, as well as other novel monoclonal antibody-based treatments. Here you see grade 3 CRS rates across the products ranging anywhere from 10 to 20%. But what's important and really differentiates CAR T-cell therapy is the ICANS rates, where we see about a third of patients, 10 to 30% of patients or so, having grade 3 ICANS, which is a significant toxicity and limits the potential for us to roll this out for all of our patients. Here is the second line data from ZUMA-7, Transform, and Belinda, which actually got the approvals for both axi-cel and liso-cel in the second line setting for those patients who had early relapse or primary refractory disease. Here in this earlier use, we do see CR rates climb up to the 60 and 70+% range. Obviously, these patients are expected to do very, very well. And if you really start to get beyond 6 months to a year without a relapse, the likelihood of long-term remission is very, very high. You can see that the PFS rates are good. We need to improve these, obviously, and we do see a long-term responders. And here is evidence of that in terms of event-free survival, overall survival for both the approved products in this second-line setting, axi-cel on the left and liso-cel on the right. You can see axi-cel has, the ZUMA-7 study has further updated data here, showing now several years of patients in remission and rather durable and actually steady remissions beyond that 1 year time point. Same story being told with liso-cel on the right. And again, we utilize these products very frequently in the clinic and have become standard of care for these unique patients that have relapsed within 1 year of their initial therapy. Obviously, we have a lot of immunotherapeutic approaches, not just CAR T, but now CD20 bispecifics have entered into the treatment paradigm for patients with diffuse large B-cell lymphomas. And it's important to remember their mechanism of action. All of the products that are currently available are CD20, CD3 binding bispecific antibodies. The FC portions have been muted essentially to avoid any of the ADCC, CDC, or other antibody-dependent cellular interactions that occur with that FC portion. And all of these drugs have unique kind of structures, but ultimately are there to activate the immune system against that large B-cell lymphoma by binding CD20, as well as an agonistic CD3 binding to the T-cell, native T-cell, and therefore enacting this immunotherapeutic T-cell based mechanism of action against the lymphoma. We have 4 drugs that have extensive clinical data supporting them and clinical approvals. Mosunetuzumab, currently just approved in follicular lymphoma, but has good data in DLBCL, and we'll see some of that in this lecture. Epcoritamab has approvals in both third-line diffuse large B-cell lymphoma as well as follicular lymphoma in the third-line setting. Glofitamab, a third-line in large B-cell lymphoma, and odronextamab has current approval in the EU, both in DLBCL and follicular lymphoma, and potentially may cross the threshold in the US as well in the future. Here's just a comparison of the big phase 2 studies that got these drugs essentially approved on an accelerated basis here in the US. And really what I want you to highlight is that they all kind of enrolled patients in the third or fourth line setting. All have similar numbers of patients enrolled on these big phase 2 clinical trials. And when you look at the overall response rates, they look very similar comparatively. We're looking about 50% of patients to respond. Obviously, you really need to get a complete remission to have durable long-term remissions, but we can see the vast majority of responders are in fact CRs. And here we see about 30 to 40% of patients achieve a CR with monotherapy approaches in this later line setting. And importantly, it's those patients who can achieve a CR can actually have meaningful and durable remissions, where we now have updated data with glofitamab with a median duration of CR of 29.8 months. This is a fixed duration approach given for 12 cycles, with the epcoritamab data being updated as well at ASH of 2024 with a median duration of CR of 36 months on a continuous treat to progression approach. And odro and mosunetuzumab also have shown encouraging data, but aren't necessarily the ones that we reach for frequently in diffuse large B-cell lymphoma as monotherapy. The CRS rates are much, much lower in terms of the grade 3 CRS rates as well as overall CRS rates, but the grade 3 CRS rates are low, 4 to 5%, and the neurotoxicity is also much improved with bispecific antibodies compared to CAR T-cell, with grade 3 neurotox adverse events anywhere from 0 to 2 or 3%. So a much improved toxicity profile. I think the efficacy might need some improvement, and we'll see the ways that we are going to start doing that. So how do we enhance bispecific antibodies, and what are the synergistic benefits of combination approaches? Well, at ASH and over the summer of 2024, we saw a lot of updated data kind of showing us where the future is moving towards. And it's not using these agents in the third and fourth line setting as monotherapy, though that's kind of where we still use them, but it is going to start to be combining these either with chemotherapy or other novel targeted agents. And so the STARGLOW study resulted over the summer at EHA, phase 3 clinical trial, showing relapsed refractory diffuse large B-cell lymphoma, mostly in the second line setting. As you can see, 62% of patients had only one prior line of therapy. And you can see high-risk patients are being enrolled, and only about 7% of these patients, to keep in mind, compared to the epcoritamab data, only about 7% of these patients had a prior CAR T-cell therapy. But this was a randomized study of glofit GemOx versus R-GemOx. And here you can see the CR rates, which as a monotherapy of glofitamab in third line and later settings was around 40%. Here we're now starting to push it up towards about 60%. And this dramatically improved the CR rates that we have historically seen with our GemOx, which is around 20% or so of these patients getting chemoimmunotherapy alone without this bispecific antibody. And so historically, the R-GemOx arm performed what we thought it would, but clearly adding glofitamab to the chemo enhances that CR rate of the GemOx, but also seems to enhance that CR rate over glofitamab as a monotherapy. This resulted in an improved progression-free survival, and as well as an overall survival benefit. And so therefore, we see great efficacy, and this has now landed it in the second line transplant ineligible patients in the NCCN guidelines, and potentially will be primed to use despite the fact that the indication is not necessarily right there as of yet. Here we see safety. The safety of combining the bispecific with the chemoimmunotherapy is not necessarily any worse than what we expected to see with glofitamab on its own. You can see the CRS really comes in that first dose of glofitamab and then starts to taper off with very low grades and low percentages of CRS going forward with subsequent cycles and beyond. And this is no different than what we see as a monotherapy approach. Not to be left behind, we do see a phase 2 kind of expansion study with epcoritamab and GemOx combination in second line. This is not a randomized study, but nonetheless is nice to be able to compare these agents. And at the end of the day, they still look very similar. Here we have 100 patients enrolled. You can see the prior lines of therapy, maybe a little bit more patients were coming on this as third line. And we do see about a third of these patients actually did have prior CAR T cell comparatively to the STARGLO study. And here we see similar response rates as well as CR rates pushing up to 60%. Again, enhancing what we see over GemOx historically, as well as enhancing what we see over epcoritamab as a monotherapy. We see the PFS rates are encouraging, and this is a treat to progression study, and results in excellent progression-free survival and overall survival, and something we look forward to further potential use in the clinic and further trial development in this space as well. Here you can see the safety as well. Looks good, does not necessarily cause any increased toxicity issues that we aren't used to or aren't able to manage, and it looks very similar to what we historically see with GemOx alone and with the bispecifics, where the CRS remains relatively low in terms of severity and at the expected time points, where we see the here with epcoritamab, the first full doses in week 3, and so that's where we see most of the CRS occurring for this regimen. So how do we redefine our treatment? How do we combine? Can we get away from chemoimmunotherapy, and can we go chemo-free with novel agents, particularly in combination with bispecific antibodies? So at ASH this past year, we saw many updates, particularly with bispecifics, mosunetuzumab, as well as glofitamab in combination with polatuzumab. Here you see a phase 2 randomized study that was presented by colleagues this past December in 2024, looking at MOS and POLA against R-POLA. And why this is unique is because many times in clinical practice, we actually don't use a lot of POLA-BR. We are using a lot of R-POLA. We can get some activity there. The chemo may not add much. It adds a lot of toxicity and actually can mess with CAR T cell collection as well as their functionality. And so many of us use R-POLA, and so that's why this study is particularly of interest and shows some great data here supporting MOS and POLA, and maybe that might be our new standard if we're reaching for a polatuzumab-based treatment regimen. So here you can see the 40 patients in each arm. You can see the median prior lines of therapy. Well, most patients coming on this third line or later. Several, a third of patients or so had prior CAR T cell. So this is where we're really thinking of using bispecifics as a monotherapy, kind of as a post-CAR T, particularly in those patients who are otherwise eligible and have had it. And we know that post-CAR T, these patients need some help. The CR rates only are about 20-25% with bispecifics, and therefore any way that we can enhance it will be important. So here you can see the CR rates with MOS and POLA of about 60%, 57.5% in the MOS and POLA arm. And this is kind of what we see with R-POLA and frankly, POLA-BR of the CR rate of 35%. So again, the POLA-MOSIN seems to enhance some response rates as well as depth of that remission and clearly improves over what historically we were seeing either with monotherapy or POLA rituximab. Here, the duration of response also looks very, very good. It's really those patients who get CRs are the ones that we are really wanting to see. But regardless, in this small randomized phase 2 clinical trial, those patients with MOS and POLA are improving over POLA-R. and therefore looks like it's ushering in a new option for our patients. And again, because of this data, we are now seeing this represented in the NCCN guidelines for patients who are transplant ineligible and in later lines of therapy. Here again, PFS differentiating itself, overall survival not quite different based on these two regimens, but nonetheless needs further follow-up time. Here, a short median follow-up time currently being reported. Of note, the safety looks really good and does not necessarily see anything significantly different or unexpected in the Mosun-Pola arm. We see CRS rates still be relatively low. Mind you, Mosun is one of the lower CRS rates of all bispecific antibodies. It resolves relatively quickly, and we see no grade 3 or 4 CRS being occurring, and all of the events resolve. And ultimately, diarrhea, neutropenia, fatigue are still common AEs seen in both groups and are frequently the Pola-based side effects that we still need to contend with and monitor. At ASH, we saw a competitor of the Mosun-Pola regimen, and this was the Glofit-Pola regimen. And here we see a maybe slightly increased activity monotherapy with glofitamab over Mosun in diffuse large B-cell lymphoma in later lines of setting as monotherapies. And so can this enhance activity and have a similar safety profile is what we are going to see here. And so this data was presented at ASH as well of 2024. Again, a similar concept, a large number of patients being treated here with Glofit-Pola. As you can see here, about a quarter of patients having prior CAR T-cell therapy, large number of patients coming on third line or later, and again, needing to enhance over that 40% CR rate. And here, it seems like the study investigators were able to do that. Overall response rates of 80%, CR rates achieving in that 60% range, similar to what we saw even with Mosun-Pola, similar to what we see with chemoimmunotherapy added to the glofitamab. And so maybe we can not necessarily even need to use the chemoimmunotherapy and just get away with targeted agent approaches, which might be easier to use and spare some toxicity for our patients. The duration of response looks great. Again, this was a fixed duration approach where the patients stopped treatment. Here you can see those CR rates being very durable as time goes on and maybe starting to plateau as we get beyond year 2. Which is really exciting and encouraging as we start to learn how do we use our bispecifics, can we use them as fixed durations, and this data looks encouraging towards that effort. The safety and CRS summary, again, glofitamab showing relatively low rates of CRS in this patient population, low grade 3 or 4 or 5 toxicities, and essentially able to be managed. Obviously, we need to be watching out for it. They occur early during the step up, and once you get beyond that first cycle or first few cycles and the first few doses, it really mitigates and becomes not too much of an issue. Again, we see neutropenia, diarrhea commonly reported. Again, part of that is part Pola, which is incorporated into this regimen and something that we need to monitor. And these are all known toxicity profiles of these individual agents. So there are other combinations that are coming around. Epcoritamab has been combined with lenalidomide in diffuse large B-cell lymphoma. This is summarizing data from ASH. Again, a large phase 1b/2 study looking at 46 patients, a smaller number of patients, but nonetheless a high-risk patient group with many of these patients coming in as third line or later. With again about a quarter of patients with prior CAR T-cell therapy, and many of these patients coming in with refractory disease. Here we see overall response rates of 60% and the CR rates of about 45 to 50% there. So it combines nicely with lenalidomide, but maybe numerically a little bit lower than what we've seen in the other studies with bispecifics plus Pola. But nonetheless, a well-tolerated and easy and effective regimen to use. Here we see those patients with earlier use of the agent, of the combination, we can have improved outcomes in terms of duration of that CR, numerically speaking here. And so again, the future of bispecific use and combinations is really to start to push it sooner and sooner, and use less and less chemoimmunotherapy, as particularly in those patients who are not going to be eligible, which many of our patients are. Here we see the CRS rates and common toxicities. We see the most common grade 3 treatment emergent adverse event is neutropenia. Again, a lenalidomide effect. Fortunately, very few of these patients translated into a febrile neutropenia. There was only one grade 3 ICANS, which resolved. Otherwise, a well-tolerated regimen. You can see most of the CRS was grade 1 or 2 in nature, and again, starts to peak at this third dose of the epcoritamab, where the first full dose comes into play. Not to be left behind here, loncastuximab also is starting to get into the fray and combined with glofitamab or mosunetuzumab. Here is data that was reported at over the recent congresses of the LOTUS-7 trial, looking at efficacy as well as safety of lonca-T plus bispecific antibodies. Again, this is like polatuzumab, is an antibody drug conjugate. Unlike polatuzumab, which targets CD79B, lonca-T targets CD19 here. So we have a CD20, CD19 targeted regimen for our patients. Small numbers of patients being reported, but 29 enrolled and having outcome data here. We see about a quarter of patients having prior CAR-T, which is a common theme and across these studies. Those with primary refractory disease and numbers of line of therapy are all consistent with previous studies. Here are the initial efficacy results based on the dose of lonca-T, and you can see high overall response rates and CR rates in the 60 and 70%. So very encouraging data. And mind you, lonca-T as a monotherapy has a CR rate of about 25% in this third line or later setting. And so clearly incorporating the bispecific antibody seems to improve this activity of lonca-T as well as potentially even of the bispecific, and they're working together and is showing another encouraging potential option for our patients to cycle through as we're targeting these various epitopes and antigens on the cancer cell. Here is the CRS and ICANS, again with lonca and glofit specifically, of 29 patients in the glofit arm. You can see any grade CRS is 34%. So there's, you do get a significant number of steroids because of the edema issues with lonca-T, and so that might help mitigate some of this as well. ICANS is relatively low, 0 grade 3 or greater. There's about 5%, 6% or so of grade 2 ICANS seen with this, but is typically self-resolved and not of significant grade 3 or greater. In addition to bispecifics and ADC combinations, there was a new agent with CELMoD, new class of drugs of CELMoDs. Golcadomide is one of the CELMoDs that is kind of increasing its development in the DLBCL space. And this data was also released at ASH, and I think it's worthwhile to note as this agent is also starting to be combined with chemoimmunotherapy and potentially even other bispecifics. And so we're seeing here golcadomide rituximab treatment for our patients in multiply relapsed refractory diffuse large B-cell lymphoma. And again, starting to show encouraging activity. Here they updated at ASH the golcadomide rituximab subgroups of patients, and you can see those patients with prior CAR T-cell. Half of them had prior CAR T-cell in this patient group. Median lines of prior therapy were 4, so many of these patients are coming on 5th line of therapy. And nonetheless, very high-risk patient population that, historically speaking, have very low CR rates and very limited options for these patients if they've been through many of these other prior therapies. Here, though, as essentially an oral pill with rituximab, we see golcadomide showing high CR rates of about 40%, overall response rates of 60%. Those patients getting the 0.4 milligram dose can do better. than the lower dose, and that's kind of the phase 2 being developed agent. And we see 40% of these patients with high-risk disease getting CR rates that are durable. Here are those post-CAR T cell patients. Again, 30% CR rate, tracking historically well with what we've seen with bispecifics in a post-CAR T setting, which is about 25 to 30%. And so, again, encouraging activity for glofitamab and rituximab. The adverse event and safety profile were mainly hematologic, as we see with IMiDs and CELMoDs, frequently neutropenia. We can see GI side effects, but low rates of non-heme AEs. Neutropenia is managed with G-CSF, and the mean relative dose intensity was close to 90% of patients achieving the dose that was intended for them on this study. So what are some of our challenges in adverse event management as part of novel treatments for our relapsed refractory diffuse large B-cell lymphoma patients? Well, what are the barriers to CAR T cell therapy? Obviously, there are patient-related barriers, there are physician-related barriers, there are logistics, there is where the patient lives and the required travel time and the disease state, just progressing the financial burden. And obviously the knowledge gap of where does CAR T potentially fit in for our patients. So this is evolving and is something that remains a barrier to effective CAR T cell therapy for many of our patients. We need to remember immunotherapy-associated adverse events. The ones we worry most about are CRS and ICANS, but there can be some more serious things like HLH, like events that occur either late and or relatively early in the CAR T cell process, and obviously late hematologic toxicity. So some patients may be neutropenic for many months and up to a year or plus after CAR T cell therapy, and it's not necessarily related to chemotherapy. It's an inflammatory process, and we're learning more and more about what that is and how to combat it. So a lot of these effects can linger even after CAR T cell is given, and we need to watch out for, and therefore why we don't think that CAR T is necessarily for everybody, and particularly our older patients, where it can be much more difficult to get them through some of these longer term side effects. And so we need to watch for them and remember that these are there, and obviously we're working with specialists typically who are specialized in administering CAR T cell products. As a reminder, CRS, the grading is essentially outlined here. A fever alone is kind of grade 1. If you start to have hypotension or hypoxia, that then becomes grade 2. But if it's responsive, it remains a grade 2. It's only when it's kind of you're needing to escalate that or it's no longer responsive, that becomes grade 3. And then grade 4 is multiple vasopressors. This is, anybody who's getting to a grade 2 should start to have an ICU consult, because grade 3 and 4 may be precipitating, and the patient is going to need intensive care to monitor and to get them through the setting. ICANS is graded here on various ICE scores that can be calculated, and with decreasing consciousness and somnolence, the grade 3 grade increases over time and severity. So be aware of the grading systems, be aware of the ICE scoring system, because this is how we monitor our patients on a daily basis, multiple times a day after providing them CAR T cell therapy. And even with bispecific therapy, it's all the same kind of concept. So the pathophysiology is relatively defined. We know inflammatory cytokines are at play here, and that's where we are starting to bring in targeted approaches to mitigate and to provide essential antidotes to CRS as well as ICANS. And so we're using our anti-inflammatory monoclonal antibodies frequently, and other targeted agents, typically tocilizumab, anakinra, ruxolitinib, many of these agents that might be that are available for use, and again, follow your colleagues' leads and be very familiar with these approaches for using and mitigating CRS as well as ICANS. CAR T cell mechanisms of resistance are broadly related to CAR T cell dysfunction, but also there's so many other, it's a multifactorial process. The lymphoma the CAR T cell, other patients' microenvironment, patient-specific factors. It's a hot area of research to fully understand this, and addressing this will help increase and improve outcomes for our patients receiving CAR T cell therapy. But recognize it's not just one standard mechanism of resistance, and it's a truly multifactorial process at play. So when we look at bispecific adverse events, we think of them very similarly to our CAR T cell toxicities, just with much less incidences, as well as less severity and shorter time to essential resolution. But the grading systems for CRS, the grading systems for ICANS are all the same. And essentially, this is a table highlighting when to expect toxicities for these various agents. Mind you, epcoritamab is mostly in week 3 when the full dose comes in. With glofitamab, it's usually the first dose at day 8 after the obinutuzumab dose at cycle 1, day 1, but can be seen throughout all of these. Again, mosunetuzumab is frequently at the first dose as well. So this again just highlights differences in the bispecifics that are clinically being used. Epcoritamab is a subcutaneous injection, typically requires inpatient administration for DLBCL at week 3 or day 15, where the first full dose comes into play. Glofitamab, you typically initiate with obinutuzumab the first week, and then on day 8, that's where we hospitalize our patient and provide them the first dose of glofitamab, which is given IV. Mosunetuzumab also given IV, but not necessarily being used frequently as a monotherapy in diffuse large B-cell lymphoma. Mind you, glofitamab is a fixed treatment duration with 12 cycles, and patients can then stop treatment if they are in these deep remissions. Epcoritamab is typically given on a treat to progression, where it's weekly for 12 weeks, every other week for another set of cycles, 6 cycles, and then beyond that can go to monthly starting at cycle 10. So here are the established therapies, as I alluded to a little bit briefly. Typically, first line is tocilizumab. It is an anti-IL-6 product, monoclonal antibody, and then steroids, which we're frequently doing both of them together. If we're using that, third line treatment for CRS will be anakinra. And then we have other emerging therapies for CRS, imaplamab, cetuximab, dasatinib, ibrutinib, ruxolitinib, and etanercept. All of these agents are out there and can be potentially used for our patients, particularly those who are multiply refractory to most of our standard frontline treatments. Again, something that our specialized cellular therapists are going to be very versed in, but just recognize that these agents are there to help our subjects, our patients with CRS and ICANS. Emerging preventive therapies, we are looking at earlier tocilizumab use or even using it as a preventative for some of our patients that might be at high risk. It's not typically a standard approach for our patients, but nonetheless is being studied and has shown some activity to help mitigate the CRS rates, or at least the severity of them, and help prevent and improve outcomes for our patients. ICANS, though, the standard is not tocilizumab. It's typically steroids, typically dexamethasone for CNS penetration, or high doses of salumedrol, which can also help penetrate the CNS. And anakinra is commonly used for ICANS as well. But typically, you think of toci for CRS and steroids for ICANS as the initial go-to for our patients. And again, can be very effective at mitigating and improving and decreasing the escalation of the severity of our ICANS in our patients. There are other established as well as emerging approaches for ICANS, intrathecal steroids, intrathecal chemotherapy, ATG, defibrotide, etc. Some of these things are not necessarily always standard for our patients, but are being studied, and we look to see this space continue to evolve in terms of how to best manage and which patients should be using these approaches for. So there is an evolving grading criteria for our hemophagocytic syndromes that are occurring. Again, can have kind of two incidences, one that can be relatively early. The CRS starts to go away, but then you start to see this hemophagocytic type of syndrome start to appear. And then there can be a very late manifestation of it as well. The grading is listed here for your interest to identify this, but obviously this is something that is not subtle, and our patients are going to need advanced therapeutics and help in this setting using some of these approaches previously described. So when we think about our patient who is presenting with an HLH-like process, steroids, anakinra, Rux, and imaplamab, which are standard approaches that we're currently using for any of our patients with HLH, but we now also employ them to our immune mediated HLH that we're seeing with our immunotherapeutics nowadays. But typically, this is the approach. Again, a table summarizing these options for you if you do see this for your patient. One thing that we can look for in terms of the long-term heme toxicities, there are some scoring systems for identifying those patients that might have risk of developing long-term hematotoxicity from CAR T-cell therapies. Here you can see some data published from some educational ASH meetings and publications. You can see you can score your patients based on their counts going into CAR T-cell. And if they are basically having normal counts, they have very low likelihood of developing long-term heme tox. But those patients who are coming in with some cytopenias and/or inflammatory markers are the ones who are more likely to be subject at risk of this, of developing this. And at least it lets you identify what type of risk it is for that patient going in, and help might mitigate whether or not CAR T-cell might be something that we do for some of these patients or not. Again, scoring systems that are out there to help identify who is best for this approach and who might we use different approaches, less aggressive, intensive approaches for. So here are some treatment algorithms for this immune effector cell associated heme tox. We typically are still giving G-CSF as a standard approach, but there are other approaches and HLH anti-inflammatory measures that we've talked about as well. We're learning of the different cytokines and the different cellular populations that might be infiltrating the bone marrow to start to target specifically. And obviously there are a lot of options here, but definitely if you're starting to see this, look into some of these publications that are out there to help manage your patient, because there are certain algorithms that we do think about using for our patients that are suffering from long-term heme tox. Here is kind of just a table summarizing when to initiate our testing for our patients for their heme tox, how to think about it, how to go about it, initial diagnostic approaches for our patients, and typically what we should do and what we might find on those aspirations and when we should be concerned. And to finalize, it's always obviously important to integrate all of our approaches and put into a specific, measurable, achievable, relevant, time-limited approach and goal for our patients, and that's the SMART goals. And it's important to integrate our biomarkers, use our evidence-based approaches to ensure best patient outcomes. Research in biomarker discovery and novel treatment modalities continue to evolve and remain important to identify those patients who are in second or third line settings, to refer them for clinical trials, and a continuing evolving landscape for effective adverse event management, which will then ultimately enhance long-term outcomes for our patients. And so with that, I'd like to thank you for your time for joining our All Hands on Deck educational activity put on by CEC Oncology. Again, spotlight on clinical advances in relapsed refractory diffuse large B-cell lymphoma, supported by educational grants from ADC Therapeutics.